We have a male, he's 21 years old, and he says, I need a checkup. We notice a non-cavitated demineralized region on the occlusal surface of number 14, and we're given an image of the floor of his mouth. And we're asked, a biopsy of the finding in this image would show what? Now, honestly, the only thing we need to answer this question is this image. We don't even really need the patient box. But before we can determine what will be in the biopsy, we need to determine what we're looking at. What we're seeing in this patient is known as bilateral benign bony protuberances, or exostoses, that are called mandibular tori. Now, these are found on the lingual aspect of the mandible in the canine to premolar region and can be unilateral or bilateral, as well as vary in size. The pathogenesis of these is currently unknown, but is debated between genetic and environmental causes. These protuberances are asymptomatic unless secondarily traumatized, and no treatment is generally necessary because they are just a bony variation of normal anatomy. Surgical removal can be indicated if they are repeatedly exposed to trauma or if a mandibular removable prosthesis needs to be fabricated, but these are just normal anatomy. They don't require any treatment. In fact, I have bilateral mandibular tori, and they don't require any treatment or cause any symptoms. Now, because these are just bony extensions, a biopsy would show a mineralized collagenous matrix with osteocytes and lacunae. This means that the correct answer would be D, osteocytes, lacunae, and mucosa. The osteocytes are responsible for the maintenance of the bony matrix, and lacunae are just the spaces in which these osteocytes are encased. Now, although this is definitely the correct answer choice, let's go through the other answer choices and discuss what lesion they would be seen in and how they're similar and different from mandibular tori. We'll start with these irregular trabeculae and islands of mineralized tissue with peripheral cementoblasts. Now, these would be seen in a cementoblastoma. We would also characterize see on the histo that the lesion is fused to the root. Now, cementoblastomas are tumors of odontogenic ectomesenchyme that are most common in the mandibular molar region, especially the first molar. They're usually seen in patients under 25 years old, are slow growing, and exhibit pain and swelling in 2/3 of the cases. Radiographically, they are well circumscribed radiopaque masses with fine radiolucent borders that are fused to a tooth root. It's a big indicator of a cementoblastoma. It's pathognomonic for a cementoblastoma. Now, treatment is surgical extraction of the involved tooth with enucleation of the lesion, or endodontic treatment of the tooth with enucleation of the lesion and amputation of the involved root. Now, how is this similar and how is this different from our mandibular tori? Now, both lesions are seen in the mandible and involve benign mineralized tissue, but they're mostly different. Now, this lesion is an odontogenic neoplasm and not a bony protuberance. Mandibular tori are not associated with teeth at all and would definitely not be fused to a tooth. Cementoblastomas are often painful and swollen and require treatment, unlike mandibular tori. And finally, what's most important to the question is that the histopathological findings are very different for the two lesions. Now, tumor islands with peripheral palisadium nuclei and central stellate reticulum areas are histologically seen in ameloblastomas. Now, ameloblastomas are benign tumors of odontogenic epithelium that are known for being locally aggressive. They're painless and slow growing, with the average age of diagnosis being 33. They're known for being dramatically expansile and will usually expand rather than perforate bone. They're most common in the posterior mandible but can occur anywhere, and 20% are associated with an impacted tooth. Radiographically, there are unilocular or multilocular lesions with well-defined borders and a soap bubble or honeycomb appearance, as you can see in this image. Now, treatment depends on the size, but involves aggressive curettage or resection with reconstruction. Now, how is this similar and how is this different from our mandibular tori? Now, both lesions are benign growths, most commonly seen in the mandible, that involve mineralized tissue, but they're mostly different. Now, this lesion is a benign tumor of odontogenic epithelium and not just a bony protuberance. These are known for being aggressive and expansile, while mandibular tori typically grow to a certain size and remain that size. They can keep growing, but they typically grow to that size that you saw in the original image and stay that size. Now, this also, ameloblastoma, needs to be treated, while mandibular tori do not. And finally, once again, what's most important to the question, the histopathological findings are very different for the two lesions, and you'd be able to diagnose off of them. And finally, Amyloid-like hyaline material and lamellated calcifications known as lysozyme rings are histologically seen in calcifying epithelial odontogenic tumors, which are also known as Pinberg tumors. So we're seeing these amyloid-like hyaline material, but when we do histopathology, we would also see calcifications known as lysozyme rings. Now, this is a tumor of odontogenic epithelium that is believed to derive from the stratum intermedium. It is a rare lesion with an average age of diagnosis being 40 years old. They're most commonly seen in the posterior mandible, may have expansion, are asymptomatic, and are often associated with an impacted tooth. Radiographically, they present as well-circumscribed radiolucencies when small and multilocular radiolucencies when enlarged. Their margins are usually well-defined, and they may show radiopaque flecks in a driven snow pattern, as you can see in this image coming off of that tooth. Now, treatment includes conservative excision, and the prognosis is good with a 15% recurrence rate. Now, how is this similar and how is this different from our mandibular tori? Now, both lesions are seen in the mandible and are asymptomatic, but that's about it. This lesion can be expansive and is often associated with impacted tooth, while mandibular tori are just bony protuberances with no tooth association. These tumors are treated via excision, while mandibular tori are not treated. And once again, most important for this question, the histopathological findings are very different for the two lesions and would really help narrow down a diagnosis. So when doing a biopsy on mandibular tori, which are just a bony protuberance that are a variation of normal, we will see osteocytes, lacunae, and the overlying mucosa. Irregular trabeculae and islands of mineralized tissue with peripheral cementoblasts would be seen in a cementoblastoma. Islands with peripheral palisading of nuclei and central stellate reticulum areas would be seen in a mieloblastoma, and amyloid-like hyaline material would be seen in a Pinberg tumor. 78-year-old male who's here for an exam. He has hypertension, rheumatoid arthritis, he smokes 2 packs per day, he's taking some medications. We recently delivered an upper and lower denture that fit well, and we noticed this raised pink lesion with erythematous center approximately 1 centimeter in diameter present underneath the left eye, and we're given a picture of how this presents. And we're asked, what is the most likely diagnosis of these dermatologic findings? Now, beyond just the really helpful image that we're given a lot of great information in the patient box to diagnose this dermatologic lesion. Honestly, the whole description of this lesion is useful. Its description of being raised, pink, having an erythematous center, its size, and its location underneath the left eye all help us make this diagnosis. So let's break it down a little bit. The correct diagnosis most commonly presents almost identically to this image, and it's characterized by this pink or pearly color with an erythematous or ulcerated center. It's commonly round and raised and about the size being described. The location is always important when making a pathology diagnosis, but this lesion specifically is known for being found in this area of the face. Now, based on the image, this description as a raised pink lesion with an erythematous center, the location of the lesion, and based on the fact that the patient is asymptomatic, we know that this is basal cell carcinoma. Now, basal cell carcinoma is a malignancy of surface epithelial origin that arises from the basal cells of the epidermis, which explains its name, and it's actually the most common skin cancer. This is most common in those over 40 with a fair complexion, and risk factors include chronic and intermittent sun exposure and frequent sunburns. Basal cell carcinoma can be seen on any cutaneous site, but affects the head and neck 80% of the time, with the middle 1/3 of the face or the mask area being the most common location, and this is where our lesion was found. There are a variety of types of basal cell carcinoma, but the most common presentation is as a firm, painless, pink papular nodule that is slow growing and has a central umbilication that we see here. That's where that erythematous center is. This lesion often ulcerates in the center and has raised rolled borders. They have no hair within them and they're pearly or opalescent when pressed. These lesions also often have a history of intermittent bleeding and then healing, making the patient think that they may have scratched the lesion. This is treated via scalpel excision, radiation therapy, or Mohs micrographically controlled surgery, and the prognosis is usually excellent. Now, although this is certainly the correct answer, and we're seeing a pretty textbook example of basal cell carcinoma, let's go through the other answer choices and discuss what they are and how they're similar and different to basal cell carcinoma. We'll start with squamous cell carcinoma. Now, this is a malignancy of surface epithelial origin, and it's actually the most common oral malignancy as well as the second most common cutaneous malignancy. And as the lesion we saw was cutaneous, we'll focus on the cutaneous form. Risk factors for this form of squamous cell carcinoma include chronic sun or UV exposure, medical ionizing radiation, and a pre-existing actinic keratosis lesion. This condition is found on any sun-exposed site, with it being found on the head and neck 70% of the time, especially the helix or upper part of the ear, face, and scalp when the hair is thin. It will grow slowly and has a variable presentation, but it can present as a plaque, papule, or nodule with a variable degree of scale, ulcer, or crust, often with an erythematous base. It's often observed as a non-healing ulcer, so patients will come in and they'll say, I've had this ulcer, it's not healing, I've had this scratch, it's not healing, and that's usually how it gets diagnosed. And this is treated via surgical excision. Now, how is this similar and how is this different from basal cell carcinoma? They're both malignancies of surface epithelial origin, they both have the same sun exposure risk factors and are found in similar areas, and they're both slow growing and usually asymptomatic for the patient. But how are they different? Now, these lesions present quite differently. Squamous cell carcinoma is not a raised, round pink lesion with an umbilicated erythematous center, but instead it's a non-healing, ulcerated, scaly patch. Basal cell carcinoma is also more common in the exact mask area, while squamous cell carcinoma is more common on the scalp and tops of the ears. Squamous cell carcinoma is also seen intraorally quite often, unlike basal cell carcinoma, and is typically a diagnosis with a worse prognosis. Next, we have melanoma. Now, although you've certainly heard of melanoma, let's talk a little bit about it. This is a malignancy of melanocytic differentiation, and it's the third most common skin cancer. The risk factors for melanoma include fair-skinned, a family history of melanoma, a tendency to sunburn or freckle easily, history of blistering sunburn early in life, and being immunocompromised. This is most often seen in patients 40 to 70 years of age, but is more common in older males, kind of like our patient. This can be seen cutaneously and mucosally, and high-risk sites are the back, arms, neck, and scalp. The common clinical signs for melanoma, and what's really important to know, are the ABCDEs: asymmetry, border irregularity, color variation, diameter greater than 6 millimeters, and evolving in size or color. The E is evolving. Now, there are different types of melanoma depending on their location and their growth pattern, and they can vary in appearance. Treatment for this condition includes surgical excision with a 1 to 2 centimeter margin, as well as close clinical follow-ups. Prognosis depends on depth of invasion and the site. Now, is this similar and how is this different from basal cell carcinoma? These are both malignancies of the skin that need to be treated accordingly. The risk factors for the two are similar, being fair-skinned, lots of sun exposure, meaning that the locations are usually similar as well. They're usually seen in sun-exposed areas. But these are different in many other ways, and they're not typically confused for each other. Melanoma is a malignancy of melanocytes and not basal cells, and the two lesions present very differently. Rather than a raised pink lesion with an erythematous center, melanoma follows the ABCDEs and presents as a brown, black, tan lesion with irregular borders that is known to change in appearance over time. Basal cell carcinoma also has a central umbilication and often bleeds easily, which is not the case with melanoma. This also typically has a much worse prognosis than basal cell carcinoma. And finally, we have eczema, which you also probably heard of, and it's also known as atopic dermatitis, and it's a chronic condition believed to be related to gene variations and too much bacteria on the skin. This condition is characterized by itchy, dry, and inflamed skin, as you can see in this picture. These symptoms can appear anywhere on the skin, and this condition is commonly referred to as the itch that rashes. Beyond just dry and cracked skin, patients can experience small raised bumps, raw and sensitive skin from so much scratching, oozing, scaling, as well as thickened skin due to acanthosis. The lesions are known to wax and wane, possibly even clearing for years at a time. There are many triggers for eczema breakouts, and the treatment usually depends on what physicians believe is causing a patient's specific eczema, so it's very individualized. Now, is this similar and how is this different from basal cell carcinoma? Now, these are both skin lesions, but that's about the only similarity. They're very different. This is a chronic condition that usually affects many body surfaces in comparison to a solitary lesion that we see in basal cell carcinoma. This is characterized by symptoms, especially itchiness, while our patient's lesion, and we would have seen the patient itching. This presents as flat, cracking, dry skin, and not as a raised lesion with an umbilicated erythematous center. And these are very different conditions, and they're just usually not confused for one another, and they're both treated very differently. So whenever you see a lesion presenting just like this picture as a raised, round, pink lesion with an umbilicated and erythematous center, especially when it's found in that mask area of the face and it's asymptomatic, it's a solitary lesion, you should always assume it's a basal cell carcinoma. We have a 45-year-old female who's here for an exam. She has systemic lupus erythematosus, and she's also taking prednisolone. And we notice on the dorsum of her tongue, there's a flat, well-demarcated erythematous lesion spanning 4 centimeters by 1 centimeter along the midline. And we're asked, what is the most likely diagnosis for this finding? Now, we're given some really helpful information in this patient box. And obviously, the most important is the description of this lesion. And all of it is important. The fact that we have the dorsum of the tongue, that's where we're seeing this. The fact that it's a flat, well-demarcated lesion. The fact that it's erythematous in color, its size, and the fact that it's found right along the midline. All of that is really important and will allow us to make our diagnosis. One other important thing that I want to point out that we're told is the fact that she's taking this prednisolone, the fact that she's taking this glucocorticoid. Now, she's likely taking it due to her lupus, and what it's doing is it's suppressing her immune system to fight this lupus. But the fact that she's taking this and we're getting this immune suppression can have other effects on her body. It can help lead to our diagnosis. And what we're seeing here, what this patient has, is median rhomboid glossitis, and I've attached a picture of what that would look like. And it kind of describes exactly what we're seeing in the patient box. That's what this lesion and what this image looks like. Now, median rhomboid glossitis is also known as central papillary atrophy, and the name of median rhomboid glossitis kind of gives it away what it is. Now, median meaning midline, that's where we're seeing this lesion, rhomboid indicating the typical shape of the lesion, what we're seeing this shape, and glossitis just refers to tongue inflammation, and that's obviously what we have here. Now, this is a well-defined area of redness found on the mid-posterior dorsal tongue due to chronic erythematous candidiasis. Now, the erythema seen here is due to atrophy of the papillae in this region. So that's what we're seeing. We see this atrophy of papillae, and it's due to this chronic erythematous candidiasis. Now, erythematous candidiasis is a less common form and more symptomatic form of candidiasis when compared to pseudomembranous, which is the more common form. Now, the tongue for this is a very common site of this erythematous candidiasis. Other forms of erythematous candidiasis can exhibit burning or tingling, but median rhomboid glossitis is typically asymptomatic, and as we see, this patient is not reporting any symptoms. Now, we emphasize that the patient was taking prednisolone because that drug causes immune suppression. Candidiasis fungal infections are the most common opportunistic fungal infections seen in the mouth, and patients who are immunocompromised or immunosuppressed are much more susceptible to them. Their bodies are unable to fight this fungal infection as well as they could, and that's why they present with conditions such as this. So her taking that glucocorticoid definitely contributed to her immune suppression and probably contributed to her having this median rhomboid glossitis due to candidiasis. Now let's go through these other answer choices, talk about what they are and how they're similar and different. And we'll start with erythroplakia. Now, erythroplakia is a pre-malignant epithelial lesion that typically displays severe dysplasia. Now, epithelial dysplasia are these disturbances of epithelial proliferation and maturation that can be seen microscopically. And there are different stages of dysplasia that increase in severity, but this is a pretty severe dysplasia. Erythroplakia is more severe than similar premalignant lesions like leukoplakia or erythroleukoplakia, but it shares the same risk factors such as smoking. Clinically, this is a velvety red lesion due to the lack of keratin production on the surface. The mucosa of the lesion is atrophic or thinned, and the underlying vascular shows through, so that's why we're seeing this velvety red lesion. It's also well demarcated and usually asymptomatic. It's most commonly seen on the lateral tongue, floor of the mouth, or the soft palate. Now, how is this similar and how is this different from our median rhomboid glossitis? It's similar in the fact that it's a well demarcated red atrophic lesion that is asymptomatic, but it's different in the fact that it's not due to a fungal infection, so it's not due to candidiasis, and it's more concerning. It's a pre-malignant lesion. It's also likely associated with risk factors like smoking and not immune suppression like we saw in that median rhomboid glossitis. This is also not really seen on the dorsum of the tongue. It can be found on the tongue, but it's usually the lateral tongue, and this can be seen all throughout the mouth, while median rhomboid glossitis is kind of limited to that mid-posterior midline of that tongue, that dorsum of the tongue. That's where it's only found. That's why it's called that. That's why it's given that name. And next, we have geographic tongue. Now, this is one of the more common oral conditions occurring in 1 to 3% of the population. It presents as multiple well-demarcated zones of erythema, surrounded at least partially by a slightly elevated yellow to white serpentine or scalloped border. Now, the erythema that's being seen is due to atrophy of filiform papillae and shearing off of the perikeratin. So the remaining epithelium that's present thins, resulting in that red appearance, that erythema. The lesions wax and wane, meaning that they heal and they develop in a different area. So sometimes they're more painful and then they appear somewhere else. They kind of wax and wane. Now, characteristically, this is also found on the dorsal and lateral anterior 2/3 of the tongue, but it can be found ectopically on other non-keratinized mucosal surfaces like the cheek. Now, how is this similar and how is this different? This is similar in the fact that it affects the dorsal tongue, so we're in the same location, and it leads to redness. And both actually exhibit atrophy of the filiform papillae, so they're kind of similar lesions. Now, what's the difference? Now, this is believed to be immune-mediated, while median rhomboid glossitis is always due to a fungal infection. Now, although this fungal infection is made more likely due to a suppressed immune system, the suppressed immune system is not what's causing the median rhomboid glossitis. Now, this presents differently with its well-demarcated zones and these serpentine borders, but that's what we see in geographic tongue, and it's also not limited to the mid-posterior midline of the dorsal tongue like median rhomboid glossitis is. It can be found anywhere on the tongue and even ectopically on other mucosal sites like we said. Now, finally, we'll talk about varicose veins. Now, these are abnormally dilated and tortuous, which just means like windy veins that are often seen in older adults. You might have heard varicose veins, you might have heard this term before, you might be familiar with it as varicose veins on the legs of older adults. And these are the exact same veins, but they're seen intraorally under the tongue or on the lip. Now, they're thought to be secondary to age-related degeneration or laxity in elastic support of the vessel wall. So as you get older, the elasticity, it kind of gives, and you get these varicose veins. They're commonly seen on the ventral and lateral tongue, like we said, buccal mucosa, labial mucosa, and lip vermilion. Now, dioscopy can be done to test if that's exactly what we're seeing. So to do this, you place pressure on the veins, and as long as they're not thrombosed, the varices will blanch. So it's a vessel, so if you press on it, all the blood that's in that vein will leave, and that's what we're doing here, and that's how we can usually test for this. Now, if it's thrombosed, it won't work, but we can usually test for it. Now, how is this similar, and how is this different from median rhomboid glossitis? It's similar in the fact that it's seen on the tongue, and it's typically asymptomatic, but that's kind of where similarities end. It's different in that it's a developmental condition, and it's not due to a fungal infection. It's seen on the ventral and lateral tongue, but it's not seen on the dorsal aspect of the tongue, which is where the median rhomboid glossitis was limited to, that mid-posterior dorsal tongue. These are also typically blue or purplish in color, and they're not red like our median rhomboid glossitis. So when we're seeing this dorsum of the tongue with this flat, well-demarcated erythematous lesion right along the midline, we know that this patient is taking a glucocorticoid. We know that what we're seeing here is median rhomboid glossitis, and it's due to chronic erythematous candidiasis. This question is asking ketoacidosis is most likely to present in which kind of patient? Patients with high blood pressure, patients with low blood pressure, patients with hyperglycemia, or patients with hypoglycemia? Now, before we can answer this question, let's define and discuss what ketoacidosis is in the first place. This condition is also known as diabetic ketoacidosis, and it occurs when the body does not produce enough insulin. Insulin is a major anabolic hormone that allows glucose to be transported and stored in cells within the body after meals. If glucose is unable to be transported and stored, the body is unable to use it as an energy source for food. When this is the case, the body will have to turn to other sources of energy, and it will tell the liver to break down fats into ketones for the body to use. These ketones are acids, and they will build up in the bloodstream and cause what is known as ketoacidosis. Keto referring to the ketones that are a byproduct of the fats, and acidosis referring to the acidic level of the blood that results. This is a condition that often comes on very suddenly, even within 24 hours. Symptoms of ketoacidosis include being very thirsty, increased urination, nausea or feeling the need to vomit, confusion, fruity smelling breath, fatigue, and stomach pain. The good thing about ketoacidosis is that it can usually be prevented by ensuring that a patient's insulin levels are well controlled. Now, based on everything we just said about ketoacidosis or diabetic ketoacidosis, we should know that the correct answer for this question is C, patients with hyperglycemia. We said earlier that ketoacidosis occurs when there is insufficient insulin to manage the increased glucose present in a patient, because there is defective or deficient insulin, or because the body cannot respond to that insulin. All of that glucose builds up but is unable to be used as energy. The body then turns to fats as a fuel source instead, and the ketone byproducts produce this ketoacidosis. Now, although we know this is the correct answer, let's quickly go through the rest of the answer choices and describe why they are incorrect. We'll start with patients with high blood pressure. Although high blood pressure or hypertension can be a side effect associated with diabetes, it is not a symptom associated with ketoacidosis, and ketoacidosis has nothing to do with hypertension. Because ketoacidosis has to do with insulin deficiency and what the body breaks down as a fuel source, increased blood pressure does not have any impact on a patient potentially presenting with this condition. And since ketoacidosis is not most likely to present in patients with high blood pressure, we know that this answer choice is incorrect. Next, we have patients with low blood pressure. This answer choice is incorrect for the same reason as high blood pressure. Ketoacidosis is a result of blood glucose levels and has nothing to do with increased or decreased blood pressure. I do want to point out that low blood pressure or hypotension can be a symptom or complication of severe ketoacidosis, as the body is reacting to the increased acidity in the blood. But because ketoacidosis is not most likely to present in patients with low blood pressure, we know this answer choice is incorrect. And finally, we have patients with hypoglycemia. Now, this was probably the trickiest answer choice. You may have just remembered that ketoacidosis is associated with diabetes and been unsure of if it was associated with hypoglycemia or hyperglycemia. Just for a refresher, hypoglycemia would indicate low blood sugar levels. And although it can be experienced by anybody who has not taken in sufficient glucose, it is mostly a complication seen in diabetics who take their insulin but do not eat in a timely manner, or their insulin dosage is just too high. The symptoms include hunger, weakness, sweating, incoherence, belligerence, disorientation, and if it becomes severe enough, it can even lead to an unconscious state. Thankfully, this can usually be treated pretty easily by just giving the patient a source of glucose, such as a glass of orange juice. Now, although ketoacidosis is very rarely associated with frequent hypoglycemia, it is certainly not most likely to present in patients with low blood sugar. In hypoglycemia, there is sufficient or even an excess of insulin in the body to manage the glucose levels. This means that glucose is able to be successfully transported and stored for energy use. If the patient consumes a source of glucose, their blood sugar levels would stabilize quickly, and there's no need for the body to tell the liver to begin breaking down fats as a fuel source. Think of it kind of like this. We all have probably been hypoglycemic at some point in our lives. You're really busy throughout the day, you forget to eat, and you start to get a little weak or disoriented because you're just so hungry. You eat something and then you feel better. Your body didn't just go into a state of ketoacidosis. A state of hyperglycemia, on the other hand, is likely not something that we have all experienced, as that is really limited to diabetics. So it would make sense that diabetic ketoacidosis is most likely seen in those hyperglycemic patients. So we know that when discussing ketoacidosis or diabetic ketoacidosis, it is most likely seen in patients with hyperglycemia and not in patients with high blood pressure, low blood pressure, or hypoglycemia.
This question asks, which imaging modality does this image depict? So let's go through our answer choices. First, we have a PET scan. This would be a radioactive isotope to glucose that we use to evaluate cell function. This isn't often used in dentistry, so we can eliminate this answer. Next, we have an MDCT scan. This is used in angiography, colonoscopy, oral diagnosis of pathology. This is not what we're seeing here, so we can eliminate this answer as well. Next, we have an OCT scan. This is when we have sectional images of tissue, and we can use this to diagnose caries or fractured teeth. This is also not what the picture here is indicating, so we can eliminate this answer as well. Finally, we have the CBCT scan. This is often used in dentistry for oral surgery, orthodontics, endodontics, or oral pathology, and it is 3D computed tomography. This is exactly what we're seeing here in this picture, so we can choose option C as the correct answer.
question is asking which is true regarding type 1 diabetes. It involves the progressive loss of pancreatic beta cells. It involves the progressive loss of pancreatic delta cells. It involves the progressive loss of alpha cells, or it involves the progressive loss of epsilon cells. Now, this is such a straightforward question and is one that I hope you can answer in 2 seconds when it comes time to take your boards. You have definitely learned this information a million times before, but just in case you forgot about it or got it mixed up, let's go ahead and talk about type 1 diabetes and what causes it. Now, diabetes is a group of metabolic disorders resulting in hyperglycemia, and it's a defective or deficient production of or response to insulin. Now, insulin is a major anabolic hormone that allows glucose to be transported and stored in cells within the body after meals. There are 2 major types of diabetes, which I'm sure you're aware of, type 1 and type 2. Type 1 diabetes is a chronic autoimmune disease where certain cells of the pancreas get destroyed by self-reactive T cells and autoantibodies. This results in absolute deficiency in insulin production. This is typically seen in younger patients and is characterized by decreased blood insulin. On the other hand, type 2 diabetes is not an autoimmune disease and is either the result of insulin resistance or decreased insulin secretion. The target tissues may not be responding to the produced insulin, or the pancreas may not be producing enough insulin for their body to function. This is seen in older patients and is associated with obesity. Now, both types of diabetes can have a number of complications and symptoms. Diabetes is the leading cause of end-stage renal disease, blindness, and lower limb amputation, and a number of other complications are also seen. As far as symptoms, the 3 P's of diabetes are very common and likely the most well-known symptoms, and they would be polyphagia, or extreme hunger, polydipsia, or extreme thirst, and polyuria, which is increased urine production. Now, we mentioned that type 1 diabetes is a chronic autoimmune disease that is due to an attack and progressive loss of certain pancreatic cells. But which ones? Type 1 diabetes is the result of A, the progressive loss of pancreatic beta cells. Now, the pancreas is an essential organ that not only plays a role in digestion, but also aids in regulating the blood sugar and other metabolic functions. Now, this organ is mainly comprised of exocrine cells that function in producing digestive enzymes, but we will not focus on these as our beta cells are endocrine cells, as are the rest of the answer choices. Now, endocrine cells make up a smaller portion of the pancreas, but these are the cells that play a role in regulating those blood sugar and metabolism levels. These cells specifically are located in clusters known as the islets of Langerhans. Beta cells specifically are the cells responsible for producing insulin. So since we know that diabetics are unable to produce sufficient levels of insulin, we know that this is the correct answer. This insulin lowers blood glucose levels and facilitates the uptake of glucose into cells for energy storage and production, and without it, the body faces serious health consequences. Because these cells have been progressively destroyed, patients with type 1 diabetes will need to supplement their insulin. Now, although we know that the cells that are absolutely being affected in diabetes are the beta cells of the pancreas, let's quickly go through the other answer choices and discuss what the role of those specific cells is. And we'll start with involves progressive loss of pancreatic delta cells. Now, these specific cells produce a hormone known as somatostatin, which serves to inhibit the release of both insulin and glucagon. This hormone helps regulate the balance between insulin and glucagon secretion, and it also inhibits the secretion of growth hormone and the release of digestive enzymes from the exocrine cells of the pancreas we touched on earlier. If these cells are progressively lost, there will be negative effects on the regulation of insulin, glucagon, growth hormone, and digestive enzymes, but it will not cause type 1 diabetes, making this answer choice incorrect. Next, we have involves progressive loss of alpha cells. Now, these specific cells in the pancreas produce the hormone glucagon, which is kind of the counterbalance to insulin when talking about blood sugar regulation. Glucagon Glucagon raises blood glucose levels by promoting the breakdown of glycogen, or the stored form of glucose, in the liver, and stimulates the release of glucose into the bloodstream. If these cells are progressively lost, the body would not produce glucagon and would therefore be unable to increase blood glucose levels in times of stress, leading to life-threatening hypoglycemia. Seeing as this is the counterpart of insulin and the hyperglycemia that is often seen when insulin levels are insufficient, we know that the progressive loss of alpha cells would not cause type 1 diabetes, making this answer choice incorrect. And finally, we have involves progressive loss of epsilon cells. Now, these cells of the pancreas are still only somewhat understood, but they are known to secrete a hormone called ghrelin, which stimulates the appetite. This is often known as the hunger hormone, and it also assists in energy balance and the metabolism. Abnormal ghrelin levels are also associated with conditions like obesity and anorexia, and if these cells are progressively lost, there will likely be metabolic dysfunction and issues with appetite stimulation. But, once again, type 1 diabetes will not result, making this answer choice incorrect. So, we always want to know that when talking about type 1 diabetes, it is an autoimmune condition that is the result of the progressive loss of the pancreatic beta cells. It does not have anything to do with the delta cells, alpha cells, or epsilon cells. If you ever have trouble keeping the alpha and beta cells apart because they have similar functions with blood sugar regulation, I always remember that alpha comes first alphabetically and glucagon comes alphabetically before insulin. So since alpha is earlier in the alphabet, it goes with glucagon, and since beta is later in the alphabet, it goes with insulin. If you have trouble keeping those two straight, hopefully that helps, but as long as you know that type 1 diabetes is due to the progressive loss of pancreatic beta cells, then you should be good for the boards. This question is asking, each of the following is a characteristic of cemento-osseous dysplasia except one. Which one is the exception? So let's talk about cemento-osseous dysplasia. It's also known as osseous dysplasia, and it's an acquired bone disorder that consists of fibro-osseous lesions. It is a benign and possibly reactive process, and it is the most common fibro-osseous lesion encountered in clinical dentistry. Cemento-osseous dysplasia is a kind of spectrum, and it ranges from periapical COD, which is the most mild form, to focal COD, which is moderate, and then florid COD is the most severe. Now we'll talk about the clinical features of COD as a whole, and then we'll talk more about each of those subtypes of severity. Now clinically, this is usually an incidental finding on an x-ray in tooth-bearing areas of the jaws, and it's asymptomatic, and swelling or discomfort is an unusual thing to see. Now the teeth neighboring this lesion always test vital. That is a very important thing because some lesions don't test vital, and it allows us to distinguish this from other things it can be confused with. And also when we do a biopsy on this lesion, we usually see multiple small gritty fragments. Now radiographically, this ranges from completely radiolucent to densely radiopaque with a thin radiolucent rim, and the PDL of neighboring teeth will always remain intact, another important detail when distinguishing this from other lesions. Now demographically, this is most common in Black females, but can affect both genders in any ethnic group. And treatment for this depends on the severity of the lesion, and we'll talk more about that as we go through each subtype in that spectrum. So let's start with periapical COD. Now this is usually seen in the mandibular anterior region, but can be in the maxillary anterior as well. It initially presents as a unilocular radiolucency at the apices of teeth with a central opacity that develops gradually, and you can see that in this image. There is no treatment indicated, and this has an excellent prognosis. Next, we'll talk about focal COD. Now, this is most often seen in the posterior body of the mandible, and it is a unilocular lesion of mixed radiopacity and radiolucency with a thin radiolucent rim. And once again, you can see that in this image on the left. Now, a biopsy may be indicated for this lesion just to rule out other disease processes because it can present as different things, but this also has an excellent prognosis. Now, finally, let's talk about florid COD. Now, this is the most severe of that spectrum, and multiple quadrants of the jaw are affected. You need at least two to be affected for this diagnosis. And radiographically, this shows multiple cotton wool type radiopacity. So cotton wool is a term that's used to describe these, and it's really associated with cemento-osseous dysplasia. And if you look at the x-ray on the left, the PAM, you can see the two quadrants, and even in the maxilla a little bit, that cotton wool appearance. Now, this is usually asymptomatic, but it may become symptomatic if the overlying mucosa ulcerates. Now, important information to know about this is that you can't place implants in these patients because the lesions are hypovascular. This causes a reduced ability for the bone to heal, and it makes the bone prone to necrosis or infection. So for treatment, you always want to kind of encourage patients to retain their teeth, because when you're extracting teeth or when you're placing implants, you're having surgery, and like I said, there's a reduced ability to heal, and your bone is prone to necrosis or infection. So we want to avoid surgical procedures because of that hypovascularization. This also generally has a good prognosis, definitely not excellent, but it can become guarded if it's infected when we're removing teeth or placing implants. Now let's go back to the question and the answer choices. So I kind of just gave you a lot of information about cemento-osseous dysplasia, but let's really break it down and look at these answer choices. And I purposefully avoided saying some of the information in that description so that we can talk about them with the answer choices. So what is the exception of a characteristic of cemento-osseous dysplasia? So we have periodontal ligament origin, cementum origin, occurs near dentition, and radiopaque lesion. Now your test taking skills are probably tingling a little bit because A and B both talk about the origin, and most things don't have more than one origin. So we might want to think about one of those two being the answer here. And I also kind of gave away C and D when I talked about the lesion. So we'll go ahead and talk it through, but the correct answer here would be cementum origin. So remember, that's the one that is the exception. That is not true, and that's because the origin of cemento-osseous dysplasia is the periodontal ligament. So let's talk about that. So this cemento-osseous dysplasia originates from the fibroblasts of the PDL. And I also kind of gave you a hint about this when I said that the PDL will remain intact. Now remember, this is a fibro-osseous lesion. Emphasis on that fibro because it comes from the fibroblasts. And what's happening is connective tissue is replacing bone. So if you know what a fibro-osseous lesion is, it'll help you remember fibroblasts are found in that PDL space, and this has that periodontal ligament origin. This is not odontogenic. It's not an odontogenic lesion, and it would be if it stemmed from the cementum. So keep that in mind. This is a fibro-osseous lesion, and that's why, cemento-osseous dysplasia, this is not an odontogenic lesion. It doesn't have anything to do with tooth structure, so it couldn't come from the cementum. So the incorrect answer, the exception, is cementum origin. Now, just to go through these other answer choices, like I said, periodontal ligament origin is the truth, so it would be wrong for this question. Your PDL will remain intact, and it does have origin in those fibroblasts in the PDL space. Occurs near dentition, I said this, and I showed you some pictures of it. It's going to be around the teeth, and remember, I said the teeth always remain vital, so that was kind of another important clue that, if the teeth are remaining vital, then obviously they're located by the teeth. These lesions are located by the teeth, and especially some of those images that I showed, they were right near the apices, so it does occur near the dentition. And you need to be near the dentition if it's going to be stemming from the PDL space. I mean, think about that. That makes sense. If it's coming from your PDL space, you kind of need to be around teeth to be stemming from your PDL space. So think about that. And then finally, radiopaque lesion. This can have a big range of presentations, but usually we are at least seeing some radioopacity in these lesions. Remember that cotton wool appearance that we saw for the most severe case here? So keep in mind that this is radiopaque. It does occur near the dentition. It does have periodontal ligament origin, but it does not have cementum origin. This is not an odontogenic lesion, it is a fibroosseous lesion. We have a 35-year-old male who says, "My mouth is very painful. He has diffuse blisters and white patches throughout the mouth, hair loss, and purple and flat bumps on the ankles and wrists." And we're asked, what is the most appropriate treatment? Now, obviously, before we can determine the most appropriate treatment, we need to determine what condition this patient has. And we're given some helpful clues as well as this picture to help make that diagnosis. The first helpful clue that we're given is this description of the oral findings, these diffuse blisters and white patches throughout the mouth. This is definitely a really helpful clue, as well as the fact that the patient said that these are painful blisters. So we can kind of narrow down our diagnosis to conditions that would include these blisters, these white patches that are painful. Another big clue is the fact that we also have cutaneous lesions. We have these purple and flat bumps, specifically on the ankles and wrists. These purple bumps are actually very characteristic and indicative of a certain condition, and the fact that they're in these specific locations is also very helpful. We can narrow down our diagnosis and know that what our patient specifically has is lichen planus, both orally and cutaneously. Now, lichen planus is a chronic immune-mediated disorder that can be cutaneous and mucosal, just like we're seeing with this patient. Cutaneously, the condition is characterized by these purple, polygonal, itchy papules with lacy white lines known as Wickham striae. And Wickham striae is a big buzzword known for lichen planus. If you hear Wickham striae, you should always think lichen planus. Now, these purple papules are commonly found on the flexor surfaces of the wrists and ankles, the shins, and the lumbar region. And that's exactly what's being described in the patient box. The oral form of lichen planus can present in two different ways, the reticular form and the erosive form. The reticular form is characterized by interlacing white lines, once again, more of these Wickham striae, and it's the more common form. The erosive form is characterized by erythema and ulcerations, and it's the more symptomatic form. That's probably what's hurting this patient. These presentations are what is being described in the patient box, and these ulcerations or open sores are what is causing the patient's pain, that erosive form. Now, oral lichen planus can be found on any intraoral surface, but is commonly found on the bilateral buccal mucosa, tongue, and gingiva. Other symptoms of lichen planus include the hair loss the patient is experiencing and changes in the fingernails as well. Now, treatment for this condition depends on the severity and the symptoms, tongue, and gingiva. Other symptoms of lichen planus include the hair loss the patient is experiencing and changes in the fingernails as well. Now, treatment for this condition depends on the severity and the symptoms. If the patient just had reticular lichen planus and was experiencing no discomfort, then no treatment would actually be needed. Now, since they obviously are experiencing pain and have more extensive symptoms, corticosteroids would be needed to treat this condition, making the answer C. Now, topical steroids are usually used on the lesions, and systemic steroids are usually not necessary unless it gets really severe. These corticosteroids work to suppress the immune system, aiming to reduce the autoimmune effect that we're seeing in this condition. Now let's go through the other answer choices and talk about why they would be incorrect for this condition. We'll start with antiviral medications. Although it is believed that lichen planus may sometimes be triggered by a hepatitis C viral infection, the condition itself is not due to any virus. Lichen planus, both the cutaneous and oral forms, are immune-mediated, meaning they are due to an overacting our own body. This condition is in no part caused by a virus, and because of this, antiviral treatment would do nothing to aid the symptoms or treat the condition. Antiviral medications would instead be used to treat viral infections such as herpes or the flu. Next is antifungal medications. Because lichen planus is immune-mediated, like we said, it is in no part due to a fungus of any kind. This means that antifungal medication would be completely ineffective at treating the condition. It's true that sometimes a fungal infection known as candidiasis can be simultaneously superimposed over oral lichen planus presentations, but the two conditions would be treated separately. Antifungal medications would instead be used to treat fungal infections such as this candidiasis or aspergillosis. And finally, we have antibacterial medications. Once again, lichen planus is immune-mediated and is therefore not caused by a bacteria. It's not caused by a virus, it's not caused by a fungus, it's caused by our own immune system attacking us. And because of this, antibacterial medications would be ineffective at treating this condition. Antibacterial medications would instead be used to treat bacterial infections such as actinomycosis or strep throat. So when we're seeing this diffuse blistering, white patches throughout the mouth, hair loss, the patient is experiencing pain, and we see these purple and flat bumps on the ankles and wrists, we know that what the patient has is lichen planus, both cutaneously and orally. And to treat this chronic immune-mediated disorder, we would use corticosteroids.